Okay, Savannah and Albany, you guys here okay to see the slides?
Yes, sir.
Fantastic. We're off to a good start.
Yeah. One of y'all do it and see if it works.
All right, guys, let's get started. It is right on time. So today's lecture and next Thursday's lecture, this coming Thursday's lecture, two-parter on adverse drug reactions. I want to spend 2 class times on it because I think it's such an important topic. And I'm gonna approach it from a couple of different ways so you kind of be fully informed on my view of adverse drug reactions, what it means, how to monitor, things that you can do to help prevent problems. So hopefully this will be a pretty complete lecture on the topic. Some of the objectives are to put things in perspective. How worried should we be about adverse drug reactions? And I think after I show you a couple of slides, you'll be convinced that we probably should be worried about this stuff because there's some things that are much more rare that we worry about all the time. Where adverse reactions are pretty common in relative terms. I want you to be able to describe the possible mechanisms for adverse drug reactions and identify some warning flags. I thought about a long time ago, I was asked to write a book chapter about adverse drug reactions. And I go, oh my gosh, how can I approach this? It'll be interesting. And so I try to look at it from some things that are setups for potential problems, and I'm going to go over those with you. It also included a couple of little graphs, 2 of my favorite graphs from a PharmD student project that was done a number of years ago that really illustrate a key point for the day. Describe the steps to implement an adverse drug reaction monitoring system, how you implement it, how you monitor it. Cite specific examples where pharmacy quality improvement projects based on reported adverse drug reactions have created really something good. So hopefully, by the end of all this, you'll say, yeah, I need to spend time with adverse drug reactions. It's worth my effort. So, put some things in perspective for you. Here's some stats I pulled up. There was a study looking at a medicine ward, just a typical medicine ward in a general hospital, community hospital. It said 23% of patients in that unit during their stay had an adverse drug reaction, and that was increased if they were elderly. I think they defined elderly, that's to be greater than 75. 15% of people receiving drugs that say they experienced an adverse drug reaction, that's probably an underreporting because they don't realize it's something happening with the drug. 1.5% of all admissions to the Mayo Clinic were due specifically to adverse drug reactions. Now, I pulled that stat a number of years ago. I think I've seen a higher percent of that these days. So I think that's probably even higher than that. In U.S. hospitals, ADRs were responsible for 4.6% of deaths, making it the 5th most common cause of deaths in a hospital. Now, if that doesn't grab your attention, I don't know, that's the 5th most common cause. And many of those were preventable, and if they weren't preventable, they were manageable. So here's ways you can jump in and literally be a life-saving practitioner in the healthcare setting. So, again, putting things in perspective. This is terms that people use to describe the risk of something happening. This is not statistics class, but it is about risk. If somebody says it's negligible, by definition, negligible tends to be thought of as less than 1 in a million. And so that's a negligible chance. Don't worry about it too much. Death due to release of radiation by a nuclear power plant. Okay, that's something people tend to worry about, but it's negligible risk. Minimal risk is like 1 in a million to 1 in 100,000. That's the risk of getting polio from a polio vaccine. You guys don't get those anymore, but when we did, that was the risk. But everybody's really worried about that all the time. Some people didn't get them because of that fear. Low risk, like very low risk, 1 in 100,000, 1 in 10,000. Death due to leukemia. And leukemia is on everybody's mind. I had an uncle died of leukemia. I worry about leukemia all the time. I see leukemia patients in the hospital. Low risk, 1 in 10,000, 1 in 1,000. That's death from the flu or death from poisoning. And think about all the efforts we put into poison prevention, all the efforts we put into preventing the flu, and that's relatively low risk. Moderate risk is 1 in 1,000 to 1 in 100. That's death from smoking 10 cigarettes a day. Now, here's my soapbox. If you smoke, stop. If you vape, stop. Do not smoke. You're healthcare providers. You should know better. And the reason I get on that soapbox very emotionally is because I lost my dad to lung cancer. He grew up in Kentucky, smoked since he was 13. Lung cancer. I lost my best friend from high school to lung cancer. Started smoking when he was about 13, fairly common in Kentucky, and totally preventable deaths. Okay? So none of that. But we worry a lot about that, and that's moderate. Now, high risk is things that happen greater than 1 in 100. Now, think about all the package inserts you've seen that have risk of various side effects or adverse reactions associated with the drug greater than 1%. GI effects from antibiotics. I mean, that's a really common side effect. But do we spend enough time talking about it, educating our patients what that is, how they might avoid it? A majority of drowsiness from Benadryl or a sedating antihistamine, it's like 20-30%. Diphenhydramine Benadryl is even more than that, but some of the other older ones. So we need to be on cue about worrying about some of these things that are high risk. They're great. They happen more than 1 in 100. This is where we do need to spend our time. Now, just for fun, all you soccer players out there, death from soccer, very low, but it is 1 in 25,000. And all my kids played soccer. If I had seen that number before they played, I wouldn't let them play. Birth control pills, very low, 1 in 100,000. But we talk about that all the time, about strokes and heart attacks and things, birth control pills. Being hit by a car, 1 in 20,000. Yikes. Be careful when you cross the street. We actually had 2 people die crossing the street here on the AU campus in the last 10 years. Hit by a car. So that's more common than you think, but still very low compared to some things about drugs. Now put this into perspective. A drug fever, while hospitalized, 1 in 100 patients. You will see this on rotation in hospitals. Somebody getting a drug fever. And it's tricky because what if the drug fever is from the antibiotic? Or if they're on an antibiotic and they get a drug fever from another drug, you think, oh, the antibiotic's not working. We still have no growth in our, for the micro lab, we got to change antibiotics or bump it up to higher level antibiotic unnecessarily. If we can play detective and think about the possibility of drug fever. Serious dermatological reactions, 1 in 500,000, but you know what? I see a couple of these a year. I think the risk is higher than that. That's what the literature says, but I think it's higher than that. You'll see what some of these Stevens-Johnson syndromes become progressed even worse than that, and it's like a major burn. This one kind of scares me. Penicillin allergy, the risk is 1 in 10 to 1 in 100. Of those, 1 in 10 is life-threatening, and of those, 1 in 10 is fatal. So drug allergies are also really important. Matter of fact, we're going to have a whole lecture on drug allergies and pseudo-allergies later on. But bringing attention to allergies and adverse drug reaction is very important. Matter of fact, I have my students on rotation. If there's any antibiotic allergies listed, but there's no description of what those are, I have them go over, interview the patient, play detective, find out what the real allergy is, then we go back in the system and describe it. Because lots of times, I had one the other day, I'm allergic to the zithromycin. Okay, so we have to go to a broader spectrum, more big gun agent. Investigate what the allergy was, gave her an upset stomach. Well, any macrolides, if you've ever taken one, that's something they do. They actually work on the GI tract. They can cause contractions. It's used that way, actually, in some cases. So it can cause cramping in the stomach. It's not an allergy, okay? But we can rule that out as a drug that can be used. So anyway, allergies are an adverse event you need to pay a lot of attention to because they're serious, or they may be labeled and cause, labeled as allergic and they're not, and cause less than best choices for therapies. Down in Savannah, I know they have a big program where the pharmacists actually do penicillin skin testing. A pretty impressive program they've started there. And they found out that the majority of patients that they skin test for penicillin allergies actually aren't allergic. So they're able to get the drug of choice rather than get some other big gun antibiotic that carries more adverse effects with it. All right, now if you're interested in these things, I put these on because I thought they were fun and I found them on the internet. So it must be true, right? So the internet. Car racing, 1 in 10,000, so don't race cars. Canoeing, 1 in 100,000. Canoers out there skiing, 1 in 1.4 million. However, skiing, if you're talking about broken limbs, you're much higher risk. Professional boxing, so no boxers in here, please. 1 in 14,000. If you lay awake at night worried about floods, it's 1.5 million. If you worry about tornadoes, it's 1.5 million. And if you walk around worried about getting hit by a meteorite, hitting you from falling from the sky, hitting you and killing you, that's 1 in 100 billion. So take that off your worry list. Don't let that keep you up at night. Okay, now, in all seriousness, this is a very important slide. This is drug classes causing some type of adverse drug reaction. So, if you're a busy pharmacist, where are you going to place your emphasis? On things that happen most commonly, right? That's where you're going to put your effort. If you have to limit it, it'd be nice to cover everything in the world, but if you have to limit your efforts, I would put my efforts in things that happen more common. Okay? Oh, here's a good one for you. Write this down. It's a good quote. Common things happen more common than uncommon things. Right? That sounds silly, right? I actually said that on rounds one day, and the physician looked at me and said, "That's the smartest thing I've ever heard." Because all the time they're dreaming up all these crazy, wild things that might be happening, and it's really just something pretty common that nobody wants to think about. But anyway, antibiotics are the most frequent class. Put someone on antibiotics, there's a high risk of some type of adverse drug reaction. It might be diarrhea, it might be a skin rash, could be a serious diarrhea, like Clostridium difficile infection. But anyway, antibiotics, you gotta monitor patients for adverse reactions. Next, and this one surprised me because I thought this would be the top list, is anti-tumor agents. Now, some of these side effects from them are a little bit more serious than antibiotics, but still, highly frequent. The third one on the list is one I also thought would be maybe possibly number one if I was just closing my eyes and guessing, is anticonvulsant, anticoagulants, because we have to monitor them, patients have bleeding. So those are the top three. Cardiovascular drugs, anticonvulsant drugs, diabetes therapy, antihypertensives, and going down the list. We're the least frequent, and this is kind of, well, the big surprise is antipsychotics being second to the least frequent. That really surprised me on the list. Would have never guessed that. Just shows you how common it is with all the other ones. But peptic ulcer therapy is not a surprise it's on the least. That's one of the drugs that went right over the counter, right? Get Pepsid, you can get proton pump inhibitors over the counter now, because they really carry with them a little bit less adverse drug reaction problems. But notice analgesics are there. And there's tons of OTC analgesics. The big problem there is a patient takes product A, product B, and product C for different things, and if they read the label, all of them contain acetaminophen, and now they got acetaminophen overdose. So being interviewed for a television program one time, and you can't tell a joke when you're being interviewed because there's no audience there to laugh. If the person interviewing you doesn't get it, it comes across as crazy. This happened to me once. We were talking about over-the-counter problems. I talked about reading labels, and I said, first there was Tylenol, then there was extra-strength Tylenol, and now we have maximum-strength Tylenol. And coming out soon is toxic-strength Tylenol. And the guy just looked at me like, really? I said, well, no, that joke did not go over well. But anyway, you can see the list. So if I were preparing for an exam, I'd probably know the most common. That's an easy test question. All right, this is one of my favorite slides ever created. It was in that initial book chapter, and it was a PharmD student project. So we were brainstorming because the student wanted to do a project, get something good on their CV. This was back in the 80s, I think. And then it was the late 80s because we did the 70s and the 80s. We wanted to know how long it took for a drug, by the time it came on the market, until a major adverse event with the drug was recognized as affiliated with the drug. So we thought, how could we do that? We thought, well, maybe what we'll do is look at when the drug was introduced, then look at the literature to see case reports of that adverse effect. And if we plotted cumulative number of case reports, when the line got flat, it's no longer reportable, which means it's probably well known by people, right? I think that's a reasonable hypothesis. So if you take a look here, let's see if we can make this work for you. There we go. Clindamycin was introduced in 1970. And I want to know how long it took for pseudomembranous colitis, a well-known serious adverse reaction to clindamycin, to be recognized by people. First year was out, no case reports. Second year it was out, the first case report. Third year it was out, maybe one or two more case reports. Then all of a sudden, people started reporting it. And when you get to right here, 1977, it pretty much flattens out. So you could say, all right, 1977, it is now well known, nobody's publishing anymore. Wow, that took 7 years for that adverse drug reaction to be well recognized. Okay, so keep that in the back of your mind. I'm going to make a really important point here in a minute. The second one we did, and again, we did a study in the late 80s, so we picked a 70s drug and said, okay, let's pick an 80s drug, see if it's gotten any better. Well, there was a third-generation cephalosporin, moxilactam, very popular. It's the first third-generation cephalosporin, super broad spectrum. Everybody loved this drug, so it was widely used. The drug was introduced in 1981. 1 year later, first case report. Another year, looks like maybe 15 case reports. Another year, starts to level off. Maybe you might argue here or here. But it was, let's see, 1, 2, 3, maybe 3 to 4 years before that was well known. It had improved since, and again, this is single drugs, it's not totally scientific. But I think you could make the argument that how long it took to recognize something improved. The reason for that is people started reporting, there was a more emphasis from the FDA about pharmacists and nurses reporting adverse drug reactions. We call this spontaneous reporting. You know that phrase because that's how sometimes I ask on the exam. Spontaneous reporting has led to shortening the times of recognizing an adverse drug reaction with a new drug. Now, the really interesting point about this is in the 90s, okay, 70s it was 7 years, 80s it was about 3+ years. We looked at it in the 90s, I don't have a slide for that, and it was about a year. And since the 2000s, it's gone down to 1 year to 6 months. Okay, so I'm convinced that that probably can't be improved on, and that's one of the reasons for, in our formulary discussions at AU, we kind of set drugs on the back burner until they've been on the market for a year, because then we know their true adverse drug reaction picture. Well, Georgia Medicaid adopted the same thing. They do 6 months though. So they won't consider a new drug for preferred drug status until 6 months. It doesn't get reviewed until 6 months because they want to see kind of more. So that was pretty cool that they picked up on that. But here's the thing to remember. The reason why it's short is because people like all you guys on all the campuses report these things. And so it gets recognized quicker and quicker. 6 months is pretty good. And it's because pharmacists have really kind of taken up the role of, if I see something, I'm going to report it. May not be exactly sure it caused it, but if your report matches multiple other reports, then it becomes known, package inserts get changed, and things happen quicker. It's been a huge benefit. Spontaneous reporting by healthcare providers has greatly improved this process. Okay? That's the take-home message of these slides. Now, I told you that I was going to want you to think about some ways when you've got a patient and you've got their profile, just thinking through how could I kind of anticipate potential adverse drug reactions. So I tried to come up with a way that I hadn't seen published in the literature anywhere that might be useful, and this is what I came up with. There are some drug-related problems that could turn into adverse drug reactions. Okay? So I said, okay, well first we'll focus on problems with the drug itself. Well, the first thing that came to mind was the dose. Maybe the dose is a problem. If you've got a drug with a narrow therapeutic window, you've got to watch the dose in order to prevent an adverse drug reaction. Think about it. Warfarin, narrow therapeutic range. If you don't give enough, the patient can throw a clot. If you give too much, they might bleed. So the dose is really related to a potential adverse drug reaction. So anytime you got a drug, narrow therapeutic window, glycosides, warfarin, and a few others out there, think about monitoring that dose carefully. is there anything about the route of administration that could cause an adverse reaction? Well, I thought, well, an unintended route, what if they're supposed to be IV and the nurse injects it in the vein, it goes in the vein, it comes out the other side of the vein, and she injects it, instead of giving it into the vein, it's actually into the tissue. That's called extravasation. And there are some drugs where I think maybe on the, if I have it on this slide, I can't remember if I've got some pictures of that on here, or it's just say for the IV admixture one. That can be devastating. If you do that with something like phenytoin, you get something called purple glove syndrome. You turn it from like, injected here and it gets into the tissue. You can turn the entire hand from the elbow down purple. And it's a tissue necrosis problem. If you extravasate some chemotherapy, oh, that's really disastrous. There's certain drugs that we could give a whole lecture on extravasation, which we're not going to do, but it's a good topic to talk about on rotations. Because there's some things that you just treat symptomatically. There's a couple of drugs that you actually have an antidote to do. Like something causes major vasoconstriction. You might inject around the site something called vasodilation. There's a couple of counteractants, but most of the time it's treating symptoms. What if the route of administration, there's different doses for different routes? I've seen this on countless cases. Let's take propranolol, a beta blocker. The dose orally for an initial dose is 10 milligrams. The dose intravenously for an initial dose is 1 milligram. The reason why the discrepancy is because the oral goes the first pass effect in the liver. So if somebody were to order 10 milligrams of propranolol and the IV, and the pharmacist says, yeah, 10 milligrams, that's what I'm used to seeing, and it was given, major adverse effects, because that was 10 times the right dose. Maybe there's something about the infusion rate or the concentration that should be concerning. Well, the one that comes into mind, vancomycin, red man syndrome, right? If you give vancomycin too fast or too concentrated, patients develop this overwhelming sense of warmth. They break out around the neck, it turns red. They feel very uncomfortable. Red man syndrome, okay, totally related to infusion rate concentration. Or simply just an antibiotic like ampicillin, very benign antibiotic, right? But you give it IV too concentrated too fast, it causes vein irritation and it really hurts. Common complaint among patients, oh man, every time you give me that antibiotic, it hurts so bad. I don't know if you ever had an IV antibiotic. If it's not diluted properly, very painful. That's an adverse drug reaction. It's totally preventable. The last drug, next drug-related potential problem is how long are we supposed to be giving the drug? If we give a drug for too long, some bad things could happen. Two classic examples, you give antibiotics too long. I think I've even mentioned that. I don't know if I mentioned this class or not. But somebody orders 10 days of antibiotics while they're in the hospital, and they have a prolonged stay. At the end of 10 days, the nurse goes to give the antibiotic, and she doesn't see it in AccuDose. She doesn't have access to it. What's going on? She calls the physician on call and says, I need to get the, she calls pharmacy. Pharmacy says, okay, reach it 10 day stop date. So the nurse calls the on-call physician, says, you need to reorder the antibiotic, it's expired. Well, this is somebody on call, they don't know the patient, so they say, okay, a verbal order for this antibiotic, and so you put it in the system, they get 10 more days. Now they might get 20 days of antibiotic, which they shouldn't have gotten. Okay? What happens? Super infection, Clostridium difficile, diarrhea, all kinds of bad things if you give antibiotics for too long. This is one of the major antimicrobial stewardship interventions you can make, is make sure antibiotics are stopped when they should be stopped. Give steroids too long. What happens? Adrenal suppression. So you have to be tapered off of steroids. Okay? So what happens sometimes is they get put on them too long. The prescriber doesn't think about the adrenal suppression and just stops them. Got a problem. They needed to be tapered. And you can prevent that adverse reaction simply by tapering the drug. So those are some drug-related potential problems. A couple more here. There's something about the preparation itself that could cause a problem. First thing that comes to mind with me is ophthalmics. More and more these days, we're preparing ophthalmics for administration. Some higher dose antibiotic eye drops. If they're not buffered, isotonic, and sterile, you might get major eye pain, you might have eye infection. So clearly avoidable adverse drug reaction if they're prepared properly. Now some excipients can cause problems. Now the example I put here was the classic one, thimerosal in vaccines. That's been taken out now, so there's no concern about thimerosal in vaccines. But there are other excipients that you can worry about. There's sodium metabisulfite, a common preservative in multiple drugs, and there are a number of patients who have sulfite allergies, and it can cause a major allergic reaction. That reaction, that sulfite reaction, is what happens when some people eat Chinese food, and they'll have a reaction to that. Or red or white wine, and they'll have a reaction, headaches usually, typically. And totally avoidable if you understand that the patient has that allergy and you avoid those things. That's a tough one though. We actually worked on a paper with the allergist a few years ago. They wanted us to come on, they had these long list of products, which ones have sulfites in them as preservatives. That took myself and a couple, I think 3 PharmD students at the time, an entire month to make all those phone calls and find out all those. I gave them back to the allergist. They wrote a paper, they let's put our name on it, which was cool. An allergy fellow wrote it, and they won the award for best fellows paper in the U.S. that year. That's pretty cool. So this is a real serious topic. Sustained release versus non-sustained release. In the hospital now, we put actually pop-up boxes to warn us. If somebody prescribes metoprolol XR, I think it is, or XL, I can't remember, the long-acting one, it should be given every 24 hours. But if they write that and by mistake put BID, you should recognize, oh, they wrote for the non-sustained release version. And so that's a good way to prevent an adverse reaction. Make sure if they write the sustained release that it's dosed like the sustained release. If they prescribe the immediate release, make sure it's dosed like it's immediate release. Okay. Pretty common problem. That's so common, we actually put pop-up boxes in our computer order entry system to warn us, hey, check this, make sure it's the right dose. The size of a tablet or capsule. Oh boy, have you seen some of the size of these capsules and tablets patients have to take? And some people literally have a problem swallowing large tablets and capsules. I occasionally have a problem. I take it, kind of gets thawed in my throat, feel it, I cough, it pops back up in my mouth and takes more water and swallow it. This can be very serious because if it gets stuck here in the esophagus, it can cause esophageal erosion and upper GI bleeding. Now, if you're a fan, I hate to tell you about all these books and stuff that we put this stuff in, but I want to tell you it's important enough we put it in book chapters. Diane and I had a chance to write a book chapter together, first project we ever worked on together, for drug-induced diseases. We wrote the chapter on upper gastrointestinal bleeding. And one whole section is on pill erosion, where people get pill or capsule stuck in their esophagus, and it sits there and erodes the esophagus. It's a very real thing. So when you're counseling your patients, you're dispensing something that's large, you can talk to them about this. This is pretty large. Let us know if you have any trouble swallowing that. Sometimes there's alternatives, breaking in half. Sometimes alternatives, a liquid formulation that they can tolerate better. Think about that. And the last drug-related one is seeing too much of a good thing. In other words, this is a drug that if its therapeutic effect happens more than you intended, it could be a bad thing. Classic example of this was, saw this on rounds once. A patient was getting a pre-op for surgery, and diazepam was a drug ID given. Nurse walked in, 5 milligram dose. You're supposed to give this 1 milligram per minute, no faster. Well, have you ever, if you think about it, grab a syringe sometime and try to push something out over 5 minutes. It's really hard, especially if you're busy. So the nurse walked in, put the IV in the line, went right in. Now, diazepam is a good skeletal muscle relaxer too. Well, guess what? All her skeletal muscles relaxed. She stopped breathing. The patient stopped breathing right there while we're on the rounds in the room. Everybody goes, like that. And they had to bag the patient, breathe for a few minutes till it wore off. And not a good thing. You saw too much of what the drug does. Okay? So that's something to think about. Is this a drug if we give too much too fast? Is there something associated with its pharmacological effect, it could be bad. An IV antihypertensive medication could lower the blood pressure too much. Okay, so kind of logical things. Okay, so that's drug-related problems. There might be some patient-related problems that sets these people up for adverse drug reactions. Here's some examples. Some pharmacokinetic variables. Is there something about this person that causes their absorption to be different? Give you an example. What if they're lying prone and really not ambulatory at all? That slows absorption. Ambulatory patients absorb things better. Is there something about their distribution that's different? In other words, they have low albumin. You got a protein-bound drug, the patient has low albumin, more free drug will be available. You may see an adverse effect more likely in that person. Is there something about the metabolism? Well, we have categories. We know genetically that some people are fast metabolizers with certain enzymes involved, and certain people are slower metabolizers. And so is there something about their metabolism that's affected? Even a drug interaction where one drug's affecting the metabolism, that could affect the drug and cause an adverse reaction. Or is there something about their elimination? Now this is an easy one. You got a drug that's primarily eliminated by the kidneys and they got kidney malfunction or some type of dysfunction, creatinine clearance below 20, what's going to happen? You're going to accumulate drug if you don't adjust the dose. So is there something about their pharmacokinetics of that patient that make them different, and we should be more careful? All right, the next one's age. Well, that's related to pharmacokinetics. As you get older, you have lower serum proteins. So you have less protein-bound drug. As you get older, your kidney function slows down. As you get older, your liver metabolism slows down. So we use smaller doses in older people, so think about that. Genetics. I already mentioned about some fast metabolism, slow metabolism. What about glucose 6-phosphate dehydrogenase deficiency? That's a genetic issue. More common in African Americans, patients of Jewish descent, Greek descent, Iranian descent. There's a list of drugs that are handled that way, and you should be careful in those patients who have a deficiency in administering those drugs. More patient-related problems. Allergies. Person who's allergic. There are patients with a predisposition toward allergies. If you have allergic rhinitis, you're more prone to have a drug allergy. So if you got somebody, really, they're in your pharmacy all the time in summertime, in the spring and the fall, getting antihistamines and stuff, they're more likely to have an allergic reaction to a drug. The elderly, interestingly enough, are more likely to have allergic reaction to a drug. That's because multiple exposures to things sensitize you to it and you get hypersensitive. And so allergies are an important patient-related problem. Now this is a big one for pharmacists. One of the worst patient-related problems that you can have is an uninformed patient. You've got to counsel patients. Do not be one of those pharmacists who you dispense a drug and have them sign the sheet that waives counseling for a new medication. Now if it's a refill, that's fine because you've already counseled them in theory. Patients need to be counseled about what to look for as far as potential serious adverse reactions. So if they experience this, they can call you, call their physician, and nip it in the bud, adjust the dose, and take care of the problem before it becomes serious. So that informed patient's incredibly important, and that is almost totally in the pharmacist's hands. So I expect all you guys to not let that happen. Okay, now let's talk about, make sure I don't go over here. We'll go as long as we can. If we get a little further than halfway, then we're in good shape for the next lecture. I just put this together one time to think about monitoring adverse reactions, kind of the thought process. If you detect a possible ADR, two things should happen, and you should have thought about this when we had first year, when Diane lectured to you about a systematic approach to answering a question, background questions. You gather all the patient-specific information, ask all the right background questions. Then look at the literature to see if anything matches that patient type with what's been published, case reports, and the ADR you're seeing. Compare the two. Compare the patient's reaction to the literature. Evaluate the severity, if you think it is related. And then you make a decision whether to continue the drug, maybe decreasing the dose or adding a drug, or discontinuing the drug and select an alternative drug. And then you evaluate the patient. Now, this last step rarely occurs. It's re-challenging the patient. One of the only ways you can really say it absolutely occurred due to the drug is when you re-challenge. But lots of times you really don't want to re-challenge. Why expose the patient to a potential adverse reaction they had before? You just document it well. Okay, now that's the end of the first part. But you know, we got, what time is it? 10 till. So we got, in theory, 15 minutes. But I won't go past it. Let's go a few more slides. This is a separate talk that I've given to pharmacy groups about implementing adverse drug reaction programs in the hospital setting. Okay. So this relates to the hospital setting, but on the very last lecture in drug information, I'm going to talk to you about drug information directed clinical services. I've already mentioned this before, I think you guys. How can you implement adverse drug reaction monitoring programs in the community? This is something that needs to happen. It doesn't quite exist right now. So you're the generation that's going to make that happen. So think about how we do it in the hospital, and it may give you some ideas about how it can be handled in the future. So this is what we do at AU Health, and to kind of give you, for folks who aren't familiar with AU Health, a little background: 478 bed medical center. It's an ambulatory care center with more than 80 outpatient practice sites. Specialized care center housing a 13 county regional level 1 trauma center. That's the highest level. 154 bed children's medical center, which has the highest level NICU, neonatal intensive care unit. AU's Health Sciences University in the state of Georgia, postgrad schools of allied health, dentistry, graduate studies, medicine, and nursing. Notice that pharmacy is not on that list because pharmacy is not part of AU, Augusta University. It's part of the University of Georgia. There's a long history behind that. It's kind of interesting if you want to investigate that. But now, with interprofessional education being influenced, more and more there's integrated learning. And it always happens on IPPEs, well, lots of IPPEs, and always on APPEs, where you're interacting with all these other disciplines, doing things together. So here's some steps to start the adverse drug reaction program. 1, develop some definitions and classifications for ADR. So what within your organization, what within CVS, or what within your 3 independent pharmacies. I guess we're talking about Barney's, that might be, how many do they have now, 5 or 6?
7.
They have 7 pharmacies. How might you define ADRs for your system? Assign responsibility for the program and obtain approval from the CEO of the, what's his name? Barry. Get approval, Barry, to do this. Develop policies and procedures, screening, handling, how you evaluate them, how you look them, so that you're able to review them for trends. And that's something we'll get into the next lecture, some of these trends that have actually developed into clinical pharmacy programs because we saw a trend of adverse reactions occurring that we could prevent as pharmacists. Promote awareness of the reactions. You do that through newsletters. So you've got a lecture on newsletters coming up. You've got a lecture on writing skills coming up. All these things. That's why I told you this was a marketable skill course that you're taking now. Probably conferences, maybe some in-services if you're an institution. Establish mechanisms for how you report them. How are you going to report them? You can use a form. You've got to just be volunteer. You're going to have some triggers that make you look to see if something bad has happened. And on and on. Okay, so this is a good place to stop because I've given you all the steps. And on Thursday, we'll look at each of the steps and see how we've touched on them at AU. And you'll be thinking about how that might be applied in the community setting, nursing home setting, smaller hospital setting, etc. Okay? All right, it's a good stopping point, so we'll stop here. And I'll see you guys on Thursday.